Uh, Good afternoon, everyone and all. I would like to thank the organizing and executive committee for this invitation to be here, and it's my privilege to be here and present this talk that I have. Cardiac contractility modulation is something that I have been engaged, and I know that here there also the different cases that we can talk about it. But this is like an innovation that device-based we try to provide for heart failure treatment. So I think it's something that when we go through the presentation and we talk the patient indication, and so I've been engaged from the beginning. I usually start a case, and I want your opinion also to see really what do you think. So this is, as I was practicing, I'm practicing in VA, this is a very typical patient. 70 ischemic cardiomyopathy, EF 25 to 30%. He already has the ICD. He had ablation, AFib flutter, and cabbage, hypertension, at the very high of every situation, comorbid situation as we go for. And I want to emphasize on that thing under a score, multiple admission over the past year for heart failure exacerbation. That is not a good sign. When you have the patient hitting the ER, they show that when the patient hit the ER with the heart failure, the mortality is 10 times more compared to a patient that is not coming to ER. So that actually a warning situation. So we need to be preventing anything possible to get this patient not coming to ER for heart failure exacerbation. This is all talk about preemptive prevention of heart failure. So, I mean, he's on good medication. I mean, typical chronic anemia of heart failure, and he's on beta blocker. He's on Entresto, and also everything. So what do we do with this? This is his EKG, very unimpressive EKG. My question is, what to do with this? Is normal sinus rhythm, tight QRS. QRS is not wide, and nothing really significant, some STT change. And so what do we do with this patient? So he is on good medication. This is his EKG. So let's do the echo. We did echo, I mean, EF the same, 25, 30%, some valve motion abnormality, regional valve motion abnormality, diastolic dysfunction, grade 3, and dilated, reduced RV function, and moderate pulmonary hypertension. Well, okay, let's cat him. See is anything we can go after. So we go and cat him, total native coronary artery disease, total occlusion, and jump graft is open. So we keep this patient, we go back, revisit him at the end. I want to show you things. So that is a typical, and I'm sure all of you in your practice, you see, this is typical situation. People, they come, they go ER, okay, increase the diuretic, give a little inotrope, and then back discharge to the next time. But I told you, this is increased mortality anytime they come to ER. Now, if you look at it, so this is a curve, this history of heart failure. As you see, risk of sudden cardiac death is all across. So the first thing is, if we get those level, we need to protect them from sudden cardiac death, which is defibrillator. So that is out. Now, what do we do now? Medication initiation of this 4 pillar of heart failure medication, SGLT2 inhibitor, MRA, ARNI, and beta blocker. So we initiate that thing. So what next? So as you see, this curve is declining, is going this quality of life. Now we get to the end of the curve. End of the curve, which is we're going to go to LVAD, we're going to go heart transplant. How many patients can reach to that? 0.05%, they don't reach to that thing. So we have this huge population of heart failure. We initiate the medical treatment. I want to ask what else we can do before we reach to that which is most of the patients don't get that thing. So we have the defibrillator in. We have to do that at the beginning for preventing sudden cardiac death. So there is a gap here. So as you see, what do we do now? My question to you guys is, what do we do now? Because I wish we had more patients for CRT. I am a believer, as Dr. Saeed, Dr. Razavi, and all of the people, you know, it is life-changing. When it came, we have done CRT, and I've seen it magic thing with CRT. But we need to have the criteria to put the CRT. And that is not too many patients. Like him, the QRS is tight. If you put a CRT, actually you increase mortality for this patient because the QRS is narrowest intrinsic. And you added this CRT, it's not going to work, it worsens the situation. So it's not. So I don't have anything. As you know, it's an epidemic situation. We have worldwide 64 million people with heart failure, and they estimated 20% of people in the adult after 40, they may have it. And it's not benign. It's not benign. Look at the mortality. These data show 50% in 5 years mortality. So we think a cancer is something, mortality in cancer? Not anymore. This heart failure, it is much more mortality than compared to cancer, and this immunotherapy, those kind of things, they have a great. So, and look at the cost. Like Medicare, 1/3 of this Medicare cost is for hospitalization of these people. Over the half of the Medicare is for hospitalization. So we have patient hitting the ER, and in a typical thing, you know, we do, okay, CAT, echo, this, that, we do, and is on good medication. What do we do now? And he's not candidate for CRT, is not, as you said, now we get to the device-based thing. So, I mean, what are the things, you know, at the very end, you know, heart transplant and LVAD or hospice if they don't want it, you know, but these are the things. I want to offer them something, if it's possible. Now, as I said, I wish we had to have this criteria, which is the wide QRS, left bundle branch morphology, to offer them CRT, but it's not the case. Less than 30% of people, they have that. So the 70% is not a candidate, and is harmful if you put a CRT. And on people that you put a CRT, there are some non-responders. So there is a lot of things happening here. So based on the Dr. Woody's research and physiologist at Mayo Clinic in 60, and you know Wood in the pulmonary unit, resistance of pulmonary is Wood. From there they said, what is the resistance? That's the same guy. So he proved that the delivery of that action potential, voltage, duration, it correlate with the contraction. So we have, if you have a longer or more potent delivery of energy, that can work to improve the contraction. So from the electricity to contraction mechanic. And this is the base of this device that Officially, they call it CCM, or cardiac contractility modulation, which is based on that idea. With this approved in 2019, with the FDA approved, and then they came with two lead system. I go through what is the thing. This is the device. It's an implantable pulse generator. We have the beauty of this thing, actually, it is rechargeable. And we have been talking, so you can, it lasts, you don't have to do change out for it after a few years. They do recharge this thing. Then the two lead pacemaker, it comes to the septum. We put it on the right ventricle septum. Now, technical thing, we need a distance between these two, about 2 centimeters. So when one of the technical things is when we put it in, we want that distance 2 centimeters with the lead. This delivers high energy. I tell you how much, about 400 more than pacemaker. So what we're delivering compared to the pacemaker is 400 times more energy delivered based on the duration, based on the voltage. So that's one reason we don't put it on the right free wall. So there is why we do it on the septum. Because on right free wall, if I put on the other side, it may catch the intercostal nerve because it's high energy. So we don't want that thing happen. One. So that is. Second, septum we're sharing with left ventricle. It is the same structure between right and left ventricle. So locally it can affect the thing. We're going to go over that. So this is the thing. This is when we increase contractility, it doesn't increase the oxygen consumption of the myocardium. So ischemic and this kind of, it doesn't. This is not happening. What it is, we have to do it. So it's a biphasic, as we said, 7.5 volts and 20 millisecond biphasic. It happened at the absolute refractory period of the ventricle, right after the QRS, between 30 milliseconds after the QRS, peak of QRS is delivered. So there is no way that it can depolarize the heart. So it's a non-depolarizing, non-stimulating, non-excitatory impulse that deliver through that time, and duration is 20 milliseconds. So as I said, it's 400 times more than regular pacemaker. What it does, bottom line, locally it does through, it augments the vagal effect. Vagal effect, it removes some of the sympathetic effect, and locally, more importantly, it handling the calcium is the one that is working. I go through the calcium. So the calcium is a nice thing that we need for contraction with actin and myosin. When the contraction comes, calcium goes to the cytosol and then contraction happens. Now, this needs to go back to the sarcoplasmic structure. So for the next contraction. So calcium contraction happens, calcium is in the cytoplasm. And endoplasmic reticulum doesn't have. For the contraction, we need to be there. So this needs to go to cytoplasmic. Two effects will happen here. One, we have calcium for the next contraction. And what is the second one? It causes relaxation of the muscle, lucitropic. It has a lucitropic because calcium makes the muscle stiff. Presence of calcium. So that is, I want to tell you, this work for contraction, and now the new study is for preserved heart failure, which is aim higher. So there are things that we don't have anything for preserved heart failure, any device to this. because it is diabetes, hypertension, treat those things. But EF is normal. What can I do? Medication. But this is the reason I emphasize on that calcium role. Calcium role is important for contraction, low EF, and calcium is important for relaxation of that muscle to go back to the sarcoplasmic. So that is the notion behind why it is handling the calcium is something that work for the also preserve and reduce EF. So as you see this, the device, they call it Optimizer Smart, it changed the gene expression of those things. As you know, this is the downregulated genes like SERCA, which is sarcoplasmic endoreticulum calcium ATPase is low, major MHC, major histocompatibility, phospholamban, their rhinorine receptor, they're all low. So when you turn that thing, they actually increase that. And we have the other abnormal gene expression, ANP, BNP, and those NCX, which is sodium calcium exchange, they kind of downregulate that. So this is, so short term, I want to say, when we put a device, even sometime I have seen it, the patient report that it is feeling better. That is right away immediate through the calcium handling of this contraction, removing calcium. Then later on, it's going to be to next phase, and this has been shown that with the 3D echo with the patient and also some ventriculographic in animal, they said it is, we increasing the EF, we decreasing the end systolic volume, we decrease that. We increase about 5 to 6% EF, and end diastolic volume decreasing. So this is now remodeling, reverse remodeling of the thing. So as we talk about it, immediate, it is minute to hours. This is regarding the handling of calcium. When we put it in, it start delivering that thing. Then we have hours to week, which is gene expression will change. And then months, which is reverse remodeling, is something that we have. There are different studies that they have been initiate that FDA approval fix heart failure, which is a European study. Then we have fix HF, which was in US, and it was a randomized feasibility study. And then we have the big one, fix HF5, which was double-blinded and randomized. The endpoint, what they have here was looking at the 5-minute, the peak VO2 to see if it is improved for as an index of heart failure. And then we look at this group of patients, then they look at it, it was 428 patients, half of them, as you see, this is a people that received the treatment, but the steepest slope, it is between the EF of 25 to 35 on that group. So it makes sense, you know. Sometimes it is when the EF is like, cutoff is really 10%, 15%. Maybe there is not much myocyte left to stimulate. Maybe it's burned out. Maybe it's something that, so the cutoff is, if really EF is less than 25%, it doesn't look like it's an option for them. But the best thing is between 25 and above. Now, there is supplement to this study, confirmatory, fixed heart failure 5C, which is they look at those people that target them as we have the steepest loop for this 25 to 45%, and then they look at the improvement in peak VO2, and they have also secondary. First, we want the safety. There is not really anything related to that device, complication related. And then we have the secondary, which is living with heart failure questionnaire. And that was the thing that break through the device designation by FDA. And remember, it showed that yes, they don't talk about mortality right there. The thing is, because it's a different thing. ICD, mortality you take. This is talking about quality of life. So, and most of the patients, they have the ICD already. So now it's a quality of life. As you see, this is improved. And look at the hospitalization. It is dramatically lower in the CCM group. And remember what just started the talk. I was talking about one hospitalization increased the mortality 10 times. So if you prevent the hospitalization, so it affects the mortality. But this study was not designed for the thing. As you see, this is comparing CRT study to CCM now. This is something that, look, this, as you see, the CCM is the green bar and the other one is the gray bar. So it is very reasonable comparing peak VO2 ml per kg per minute, so even 1.7 increased it. Then we have quality of life. To be meaningful, we want 5 points improve. And you see that comparing to CRT for the control, as you see the 11%. And then 6-minute walk comparing to CRT. So they compare this thing to CRT, and they are, at least, it's not inferior to that. They are something that we may think about it. And people improve New York Heart Association classes, 80% they improved, and most of the time, this. So once again, heart failure is, regardless of any type of practice, this is something that we all dealing with. Then as roughly 50-50, roughly preserved and reduced heart failure. So that is something. And so now what do? We'll talk about the gap in the treatment. We have the defibrillator, we have the guideline-directed medical therapy, we have all of those things. Is there anything else we can offer? That's the question, on top of this thing. And so I think there is a room for this thing. If you see that in 2019 it was approved, and the trajectory of this thing could be, you remember the CRT when it came, it takes about 10 years to be something, all of those miracle study, companion, those kind of things to put a thing. And this is started 2019. So the potential is there are room for this device, as said. Now, there are something, actually new guideline. As you remember, this is approved. This is based on the 2019 approval, FDA. So Optimizer Smart System delivers CCM therapy indicated to improve 6-minute walk, quality of life, functional status of class 3 heart failure to remain symptomatic despite guideline-directed medical therapy. Who are in the sinus rhythm? No, we can do it for AFib. So this is the initial thing. So we can do it for AFib. Are not indicated for CRT? No, the guideline is they are not receiving the CRT. That's different. Not indicated is not indicated for CRT. It's replaced, the new guideline is they are not receiving the CRT. And AFib is not the issue. So who doing it? Anybody do device. Pacemaker is basically a pacemaker, high output pacemaker. Technically, and we talk about it, we're going to put it on the septum because we said that maybe it catches the intercostal because it's a high output cause contraction here. So we're going to go put it on septum because we're sharing the septum with left ventricle. Now, other thing you need to know, I mean, most of the people, they have a defibrillator when you see. So most of the time it's going to be right-sided implant. Right-sided implant, because they already existing ICD there. Now, we talk about what is happening. Actually, there is combined devices coming. CCM ICD, they call that Integra D. And I am one of the PI for that to run it. We haven't implanted yet, but this is something combined CCM plus defibrillator, which is, they had some manufacturing problem to deliver on time, but that's something that, number two, I talk about the preserve EF. Aim higher. So this is like more than 45% ejection fraction. For the people, there are two big studies, they are talking about CCM, combined CCM, Integra D, defibrillator and this, and then the other one, aim higher. So this is also changed, the CRT he's not receiving, if for whatever reason he's not getting the CRT, you can offer them the device. And so we talk about, back to our patient. Now I want to look at this. So this is, as we said, on the right side, on the left side, he has a defibrillator, existing defibrillator. On the right side, we implanted this CCM, Optimizer Smart. And we have the dual chamber ICD, dual coil, and these are the pacing, these are the lead that, as you said, now there are a little technical, you're going to put it on the septum. Nowadays, we all do this left bundle pacing, we always put it on the septum. This is almost the practice to put a pacemaker on the septum, not in the RV apex. So, as you see, there are a distance between the two lead, and there is a distance between the two lead and defibrillator lead. So we want 2 centimeters as a general rule between any of those things, 2 centimeters. And when we put a defibrillator, we put the highest output of this device and the most sensitive of the defibrillator to see if it is interaction, device-device interaction. So we do the highest sensitivity for the defibrillator, highest output for the thing, and see if there is far field or device-device interaction. So, and you see this is a LIO view, and nicely is showed that lead is there, apical, defibrillator apical, and then we have 2 pacemaker lead, which is, you can do any pacemaker lead, but I would rather to put it on the septum with the left bundle type of pacemaker. I like the smaller, thinner lead, like 3830, because I want less volume in the RV. So we do that. Hopefully from now on, maybe we just do one device, CCM and a defibrillator. And that is a thing. And so what it does is rechargeable, 5 interrupted session, 1 hour each, for 1 hour each session of delivery, and then 3.8 thing is rechargeable and longevity, which is a great thing, you know. You don't have to go for the change-out or anything. This is the battery and generator, pulse generator, and then that's the charging. Now, this patient, after implant, as you know, we have the ICD, shows the volume status of the patient. Is it optimal or heart logic, or any device has that potential to see if there is volume overloaded or if there are something. Look at this. We implanted, look, before was really volume overloaded. And this is after. So this is, something is working. Patient was feeling, and I just did a device. I was not aware of this. You know, I had a text that this guy is EF improved from 30%. I just had a, 2 days ago, this thing. 2 days ago text, we did it a couple of months ago, and now is about 45% EF. And the guy is really happy. I think, my thing is really, while we can offer something, it may be something on top of everything that we offering medication. I truly believe that all of those medication work, and we have seen it. It's great data. And so I was thinking, I think I'm done, huh? Dr. Saeed? Yeah. Did I go over time?
Just a little bit.
Yeah.